Well, good evening. Welcome to the EDS Awareness Educational Series webinar. My name is John Furman. Before we introduce our speaker, we'd like to give you an overview of the free program for those attending for the first time. So we'll go over who we are, what is our program, a newer program that we're just starting that we'd like to tell you about, and we'll introduce our speaker at that time, and there will be a Q&A. So again, my name is John Furman. I manage the National EDS Awareness and Chronic Pain Partners nonprofit organization based in Cincinnati, Ohio. My daughter, Deanna, leads the Cleveland, Ohio EDS support group, and she was diagnosed with hypermobile EDS in 2008. That was the same year my wife, Carol, passed away with breast cancer. I was a caregiver for my wife who struggled with undiagnosed EDS for over 30 years. So we introduced our program at the 2012 EDNF conference to help EDSers form independent local support groups and spread EDS awareness in their community. We have been a sponsor for those conferences for the last 7 years, and we've started over 116 support groups to date. Each group is given their own free website with a link to the directory and map. We receive feedback that conferences provide valuable information and social opportunities, but many cannot afford physically or financially to attend in person. So we decided to bring the speakers to you through the free EDS Awareness Educational Series. We typically meet monthly. It's 7:30 p.m. Eastern Daylight Time. All of the programs are free. The meeting announcements and whenever possible, the webinar recordings will be posted on our website at edsawareness.com for later replay. You can receive email announcements for future sessions by requesting the free report on our site. Tonight's presentation is sponsored by Body Support Store, where you'll find over 250 products selected by EDSers for EDSers. Proceeds from our store and donations to our nonprofit organization help fund our programs. Please visit the store and check out the helpful products that we provide. So just a general disclaimer. This presentation contains general information about EDS. Members of the EDS community voluntarily participate in this program. The information is not advice. If you're having medical problems now, please call 911 or the emergency services in your location. Always consult a doctor before making any changes to your treatment. Again, this is a very sensitive topic. We have actually delayed getting some topics onto our site. It took us a while before we talked about cannabis. But this, again, is a topic that just isn't discussed enough, and Cathy has a lot of knowledge about it, so we're looking forward to hearing her perspective on this topic. So, again, you can ask questions, and what you need to do is click on the Q&A button, type in your question, and click the orange button to submit. Now, these questions will be answered in the order that they were received. So we're very excited about our physician CME education program. We've had that up for about a year, and we've had over 1,000 participants who have registered on the site. And we have 5 programs up, and we're continuing to add programs to that site. So it's receiving an overwhelming response from the medical community. We're also working on getting accredited to a nurse's CEU program. As a patient, you have the opportunity to make a difference and improve awareness and understanding of EDS by encouraging your physician and healthcare providers to participate. You can provide them with the link to the site, which is Danlos-CME.org, or you can print brochures from the CME site. Go to the brochure button, click on the brochure, and there's a color brochure. You can either print it in Vistaprint or you can download it in a PDF format. So we're very excited to have Cathy Pederson PhD as a presenter this evening, understanding the relationship between chronic illness and suicide. Again, I'm very sensitive to this. My daughter, or my wife in the Cleveland area started the first crisis suicide hotline back in the 80s. And it is still in operation and has had thousands of visitors. So this is an extremely important topic. Also, last month was Suicide Prevention Awareness Month. So very important topic to be discussing and learning about. So again, Cathy Pederson PhD is a professor of biology at Wittenberg University. That's in Springfield, Ohio. She's a founder of Standing Up for POTS and started that program in 2014. She's a facility member of Wittenberg University, Department of Biology, since 1995. She has a PhD in neurobiology and physiology, and from Rutgers in, again, 1965. BA in biology, Wittenberg University. Her major areas of interest is quality of life of people with chronic illness and suicide thinking and risk. POTS is a big focus for her, and again, the Standing Up for POTS program, we've participated in the past. She has walks in Springfield, and we participated last year, and there's one coming up I think next week. So she has a website, so go out and check that out, Standing Up for POTS. So give me a second, we'll bring up her slides and we can get thank you.
All right. Well, thank you again, John, so much for inviting me to come and speak with the EDS Awareness. I'm really honored to be here. I come as a faculty member from Wittenberg University, the founder of Standing Up to POTS, and then also the mother of a chronically ill child. And so what I'd like to do today is just start a little bit talking about chronic invisible illnesses, and then we'll work our way towards suicide and what we need to be thinking about. I think many of you are intimately familiar with chronic invisible illnesses, but I'm not sure that the general population really is. And so a chronic illness, of course, is one that's prolonged, that we have trouble fixing. We don't have good medications. They don't go away spontaneously. And unfortunately, rarely are we able to cure those completely. So what we find is that people with chronic illnesses like this have a debilitating set of symptoms and decreased quality of life, but typically those disorders are not fatal. The invisible part of it, again, many of you are probably familiar with this, is the fact that, number one, you don't necessarily look like you are ill. So everything on the outside appears to be healthy, even though you feel terrible on the inside. And then the second part of that is the fact that we don't have good testing for a lot of these illnesses. So when physicians or other healthcare practitioners run tests, they run blood tests or urine tests or some sort of scan, everything comes back normal, when again our bodies are telling us that things are anything but normal. And most of these illnesses are found mainly in women. That's not to say that men don't get them too, because of course they do. But women over history have been looked at as hysterical. when we have symptoms that people can't see, that we can't prove what's going on there. So I want to talk about some chronic invisible illnesses, call a few of these out sort of separately, and I know that there are many more chronic invisible illnesses, but I needed to limit the scope for this evening. I'm going to start with postural orthostatic tachycardia syndrome, or POTS, and this is a diagnosis that has not been heard of by many people, even though there are likely up to 3 million cases of postural orthostatic tachycardia syndrome in the United States alone. And when we look at the demographics for this, what we find is that about 75% of these cases are women between the ages of 15 and 50. And alarmingly, about 1% of teenagers have POTS. So you could walk into a high school and chances are there will be several, usually young women, who have that disorder. There are a number of triggers that can cause POTS, but the truth is we don't understand the underlying etiology. We know that many people develop POTS after a viral infection like mono or Lyme disease. For others, it's pregnancy that acts as a trigger for their POTS. And in other cases, it's surgery or other trauma. We know that some people get it after concussion. And so it looks like there are many different triggers to cause this syndrome. What we see with POTS is that, again, the blood tests and other tests don't work very well, and a poor man's tilt test is what we can really use to see this. So when people lay down for about 2 minutes and then take their pulse, and then stand up still for about 2 minutes and take the pulse again, in an adult, if there's an increased heart rate by 30 beats per minute, then that could be indicative of POTS. In children, it has to be a little higher, so 40 beats per minute increase upon standing, without any significant change in the blood pressure. With POTS, this is one form of dysautonomia. There are a number of these. This is the most common form of dysautonomia. And a dysautonomia is where the autonomic nervous system is not working correctly. The autonomic nervous system is the automatic part of the nervous system. And so it controls the things that you can see on the screen there. Heart rate. So again, when you stand up, you get this tachycardia. Your heart starts racing. It can affect the blood vessel diameter, again, especially when changing position. And so you'll see blood pooling in the extremities where the hands or feet can turn red and purple as a result of this. And it can also lead to lightheadedness, dizziness, and headaches, again, particularly upon standing. About 40% of people with POTS actually will faint when they're standing upright. It can also affect things like pupil diameter, which regulates how much light moves into your eye. And so we see light sensitivity in a number of people that have POTS. The autonomic nervous system also affects food movement through the GI tract. And so many people with POTS have a symptom that's called gastroparesis, which means that the stomach or intestines are paralyzed or partially paralyzed. And of course, this means that there's trouble moving food through, absorbing the food, and getting the nutrients that person needs. And then the last symptom that I'm going to call out is body temperature, where even in these teenagers, you can see them hot flashing 1 minute, and then a few minutes later, they are absolutely in chills and freezing. A second chronic invisible illness that I want to touch on tonight is myalgic encephalomyelitis and chronic fatigue syndrome. These two disorders are related and both deal with unbelievable fatigue. And so the estimate is about 1 million people in the United States have myalgic encephalomyelitis or chronic fatigue syndrome. And again, mainly this is in adult women. There are a number of triggers for these disorders as well. Viral infection and hormonal imbalances have been known to trigger these disorders. And what we know is that, again, just like POTS, there are problems with the nervous system. And so we're going to see problems with confusion and brain fog in a minute. We also think that the immune system is not working properly in people with these disorders, nor is the energy metabolism in the cell. And so if they can't make and use ATP properly, that really limits the function of the body. And then the last one is ion transport in and out of the cell. You may recognize the picture that I put up here. This is Jennifer Bria, who was the producer and star of the documentary Unrest, who really has brought a lot of awareness both to this community and to the chronic invisible illness community as well. Some symptoms that we see with ME and CFS are unrefreshing sleep. And so a person with this disorder may sleep for 8 or 10 hours, and they get up feeling just as fatigued as they did when they went to bed the night before. And so taking a nap or sleeping at night does nothing to help their fatigue. Headaches can be common in this population, as well as issues with memory and concentration and paying attention. And so a lot of times people will talk about brain fog as a symptom of this disorder. Again, related to the dysfunction of the immune system, a lot of times they'll have enlarged lymph nodes and then a lot of pain that's unexplained. Nothing comes up on the testing. This can be muscle pain or it can be joint pain. And then the hallmark, I think, of these disorders is that extreme exhaustion. And a lot of times people will talk about rebound fatigue, where they have a lot of fatigue 24 hours after they went to a family gathering or after they did some sort of an outing, where they are literally in their bed unable to move for another day or two. A third disorder that I want to talk about tonight, of course, is Ehlers-Danlos syndrome, and I know many of you are familiar with this since this is an EDS awareness presentation. This is a little different from some of the other ones that I'm going to talk about because it's a genetic condition. This is not something that people are going to catch after an infection or after some sort of trauma. This is something that you inherit. And it affects the connective tissue, particularly collagen, that is supportive tissue in many parts of our body, so skin, bone, blood vessels, and most of our organ systems. And you can see in the picture there that people can have a wide range of symptoms. I'm showing some hypermobility in the picture there. So some people will have just mildly loose joints that don't cause them too much problem. And then others have life-threatening complications, and I'll come back to that in a minute. There are 13 different types of Ehlers-Danlos syndrome, and most of those include some sort of hypermobility. And again, when you look at the syndrome, about 1 in 5,000 people are thought to have Ehlers-Danlos syndrome, and that's all of the types combined there. So what we see in this connective tissue disorder, again, is this idea of loose joint articulation, where bones will slide out of position. If they don't go out fully, that would be a subluxation. If they completely move out of the joint, of course, that would be a dislocation. These can be very painful for people.
Yeah,
you can see in the picture there that there also can be issues with the skin. So that skin can feel very soft and velvety, but it can also be stretchy. There can be abnormal bruising and scarring that comes from very light touch or impact. And then particularly found in the vascular type of Ehlers-Danlos syndrome is tearing of blood vessels that can lead to internal bleeding and organ rupture. And, of course, this is the part that can be life-threatening for people with some form of Ehlers-Danlos syndrome. Fibromyalgia is another one that fits into this category of chronic invisible illness. I think a lot of the general population has heard this term maybe more than some of the other ones I'm going to talk about tonight. And you can see that the numbers are up a little higher in the United States. About 4 million people have been diagnosed with fibromyalgia in the United States. And again, this disorder largely inflicts adult women. So 75 to 90% of all cases are adult women. Again, that's not to say that men don't get fibromyalgia or any of these other disorders, but they do seem to be predominantly in women. Some triggers for fibromyalgia include physical trauma, surgery, infection, and then significant psychological stress. So very similar to what we've seen before. I want to point out on that last point that this is not a psychological disorder. This is a physical disorder, but when people are under a lot of stress, that can be a trigger for this syndrome. In fibromyalgia, it's interesting, they have changed the diagnostic criteria in the last few years. They used to look for a series of sensitive points throughout the body, and the diagnosis now is widespread pain that lasts more than 3 months, that's found bilaterally, so both sides of the body, and both above and below the waist, so that they've become a little bit more general in the way that this is diagnosed. And again, like some of these other syndromes, a lot of fatigue, cognitive difficulties, brain fog, and trouble with concentrating. The last one I'm going to point out tonight, and again, I know there are so many others, but the last one I'm going to talk about tonight is Lyme disease. And this one is a little different as well because this is an infection. And so I think a lot of people, particularly in the Northeast, are familiar with Lyme disease. And there are about 300,000 people who are diagnosed every year with this disorder. And it's transmitted by the bite of a tick, the black-legged tick, or a lot of people call it the deer tick. You can see pictures on the right over there of the female and male, and then the nymph and larva. And so they do look a little bit different there. And some of the early symptoms of Lyme disease include fever and headache, fatigue, and then the bullseye rash that, again, you can see over on the right side of the screen. Notice that rash can look a little bit different. It can present a little bit different. And I want to point out again that not everybody gets this rash who has Lyme disease. So if you see the rash, definitely you need to go to the doctor. But not everyone who's been bitten by an infected tick actually sees that. The great news about Lyme disease is that if it is caught early, we can cure it with antibiotics. Those aren't the people I'm talking about tonight. The ones I'm talking about tonight are the ones that have chronic Lyme. That's untreated Lyme disease. And it's where the disease has been allowed to progress without antibiotics. And there are a lot of really debilitating symptoms that can come from this. So again, severe headaches and dizziness, problems with short-term memory, so remembering where you laid your keys or things like that, neck stiffness, a facial palsy, which can look like a little bit of paralysis of the face, like a Bell's palsy sort of thing, rashes, arthritis, and then again, this is a pain syndrome, where the pain can be in the tendons, muscles, joints, and bones. And then the last symptom there is heart palpitations, where you can feel your heart beating in your chest. And so once it becomes chronic Lyme, it's much more difficult for us to treat. That bacteria has really taken over in the body and has caused some damage before we get in there with a good diagnosis and some antibiotics. In all of these disorders and so many other chronic invisible illnesses, there is significant impairment in the quality of life. And this is what I'm really interested in trying to spread the word about how debilitating these really can be. So there are a lot of problems that can occur, some of these with general health, and you can list all the symptoms that we've already talked about. Sleep is a big one. Brain fog is common in so many of these chronic invisible illnesses. And then pain, whether that's neuropathic pain, I'll talk about that in a few minutes, migraine headaches, abdominal pain, muscular and joint pain. So many of these have significant impairment in function because of pain syndromes. And this affects us physically, the ability to move outside of the home and social functioning. I did a study with my friend Jill Brooke a couple years ago that we published in 2017. And some of you might have participated in that study, and I thank you for doing that. We asked people in the POTS community, but also those with EDS and chronic fatigue syndrome, if they would fill out some quality of life surveys. And so this is the results of the first survey that we did. And what Jill and I found was that a significant minority of people that took those surveys needed help with activities of daily living. And that includes things like eating, where maybe they can feed themselves, but they can't cook the food or go and get the food. And in some cases, they need help literally getting the food to the mouth. Help with bathing, with brushing teeth or hair, with dressing themselves and moving around the house. And again, if you consider that we're looking at women who are young adults into middle age, this can be very debilitating. Let me talk about some common symptoms for a variety of chronic illnesses. And the first one I want to talk about is chronic pain. And I know many people with these chronic invisible illnesses have a lot of pain. And it's very difficult for physicians and other healthcare providers to understand and to believe, partially because we don't have a good way to detect it. Again, there's not an MRI or a blood test or a urine test that allows us to quantify pain or to diagnose pain. And so right now you go in and the doctor says on a scale of 1 to 10, what is your pain level today? And that makes it very difficult for the patients sometimes to be believed and for the physicians to really understand what's going on there. Many people with chronic pain have neuropathic pain, and this can be in a variety of formats, actually. It can be a shooting pain that goes up and down arms and legs. It can feel like a stabbing pain or a burning pain, stinging. It can be very painful, and in a lot of cases, unfortunately, this is a 24/7 pain, and a lot of medications don't do well at treating this neuropathic pain. We also know that many people with these invisible illnesses also suffer from headaches, whether we're talking about cluster headaches, tension headaches, migraine headaches. And some people, the headaches, again, never goes away. They've got that 24/7, or they'll have it more days of the month than not having a headache. Very debilitating. Abdominal pain in the same way. For some people, after they eat, they feel like they just need to curl up on a ball on the floor. They have so much abdominal pain with intake of food. Chest pain is not uncommon. Could be from subluxing a rib, a variety of other things as well, and then that joint pain. So unfortunately, there's a lot of pain that comes with these chronic illnesses. And chronic pain is it's a difficult one for a number of reasons that I'm going to talk about. One of them is that our central nervous system, our brain and our spinal cord, become sensitized to pain. So the more pain we have, the more our central nervous system is sensitive to pain. I think the easiest way to think about this is to think about a highway. Think about a 2-lane highway where there's a lot of traffic. And so the city or the county comes in and they say, okay, there's a lot of traffic here. We're going to expand from 2 lanes to 4. And so people are like, wow, this is great. More people take the route. And again, the roads become clogged. And so the county comes in and they make the 4-lane highway a 6-lane highway. You get the idea. Exactly the same thing happens in our brain and spinal cord. So the more pain we experience over time, the more sensitive we become to pain. The more sensitive we are to pain, the more pain pathways we build in our brain and spinal cord, and the more sensitive we are to pain again. It is so critical to try to treat this pain within the first 6 months of its development. Several studies have shown that once the pain is established longer than that, it is much harder to treat. It's not impossible to treat, but it's easiest to beat back that pain in the first 6 months. And so we need our healthcare practitioners to jump on that right away. There are a number of factors that can increase this sensitization. And so, again, if you have an autonomic nervous system dysfunction, like people with dysautonomia do, that increases the likelihood of sensitization. In others, it could be a genetic predisposition, where we know that pain syndromes can run in certain families. Infections and inflammation can increase sensitization, your body's response to that pain, as well as trauma, psychological factors, and poor sleep. And again, I want to point out that this pain is not from psychological factors. I'm just saying that those factors can increase the pain that is already there. This chronic pain is prevalent in all of the disorders that I'm talking about tonight, and again in so many other chronic invisible illnesses. And the reason that this is so important is because, again, this pain can severely impact activities of daily living and quality of life. And there are a number of studies that have shown an increase in suicidal thinking and in suicide attempts in people that suffer from chronic pain compared with people who don't have chronic pain. And so again, we need to get after this. We need to really be working on treating this pain. A second factor that is really common to people with a variety of chronic invisible illnesses is sleep disturbance. And many of you might also suffer from sleep disturbance. And this can look like a lot of different things. Again, I'm taking this from a paper that I did with my friend Joe Brook a year ago. And we found that in people with a lot of these chronic invisible illnesses that they had decreased sleep efficiency. And what we meant by that was that they spend a lot more time in bed than they spend sleeping. And so it may be that you go to bed, you feel very tired, and it takes an hour or 2 hours or longer to fall asleep. For other people, they'll have nighttime wakefulness. So maybe they fall asleep quickly, but they wake up every 2 hours all night long. And then the last one is early morning wakefulness, where again, maybe they fall asleep and they stay asleep, but they wake up at 2 or 3 in the morning and can't fall back to sleep again. And so this is a problem, right? Various forms of insomnia that can really disrupt quality of life. We also found that there was a higher incidence of nightmares in people that had these disorders compared with the healthy controls. We know that sleep disturbance is complicated, and for many with chronic invisible illnesses, it can be related to that pain. If you're feeling pain that's 9 out of 10 all of the time on the 0 to 10 pain scale, it can be hard to fall asleep over that pain. If you're someone with POTS who has sympathetic surges, that's a surge of norepinephrine, of adrenaline, as you're trying to go to sleep, it's hard to sleep with that. Lack of exercise, and I can hear a collective groan, even though you're muted there. Lack of exercise is a problem, but I'm not saying that it's something that we can necessarily do a whole lot about, depending on the severity of your illness. And then poor sleep hygiene. It's so tempting, if you don't get a good sleep the night before, to take a nap in the morning or the afternoon for an hour or two, but that ends up exacerbating the problem. Again, it's important that we deal with sleep disturbances because these have been shown to increase the risk of suicide in these chronic illness populations. Another symptom that's common in chronic illness is fatigue. And so many people with these chronic illnesses have unbelievable exhaustion that, again, is not relieved by rest. And it's not the same as feeling tired after a long day's work if you're healthy. The best way I can describe this fatigue is the fatigue that you might have when you have the flu or pneumonia, where you just don't want to move off of that couch or out of that recliner. And there may be things that are fun and interesting and that you plan to do with family or friends, and you are just not interested. You are so fatigued you don't want to move. Imagine that kind of fatigue, not lasting for days, but lasting for months, for years, and for decades. And for people with these chronic illnesses, I think that that kind of fatigue is similar, but for much longer. And so they have reductions in energy, in motivation to do the things, even if it's things that they really enjoy, and in their emotional well-being as well. For many, this can be the most debilitating symptom of chronic illness. And in the chronic illness community, many end up in wheelchairs, not because they can't walk, but because of this unbelievable, unrelenting fatigue. The last symptom that I want to talk about that can be common in chronic illness is depression. And again, I can feel the hackles going up as I talk about this. And I understand that. I know that so many people, my daughter included, were thought to be anxious or depressed before we found the physical illness, the chronic illness that was the true cause of her problems. But we do know that there is a true link between these chronic medical illnesses and depression, and not just for those of us in the chronic invisible illness community, but also for those with heart disease and with cancer and other really well understood and well supported illnesses. There was a study a few years ago that showed that about 50% of people who suffer from chronic pain actually also suffer from depression. And in a study that I did with my friend Jeff Brookings, again, a survey that many of you might have filled out, thank you for that, we found that about 35% of those with POTS and then other comorbid disorders like chronic fatigue syndrome, EDS, fibromyalgia, also reported severe to extreme depression as well. Now, when we're talking about depression and chronic illness, we have to be careful. And I think a lot of us that live in this community understand this, and this is something that we're hoping that our friends in the healthcare profession will become a little bit more sensitive to. Here's the problem. There are a lot of depression screenings out there, but they're contaminated with questions about physical symptoms that for those with chronic illnesses are going to artificially increase the depression scores. And so you might be able to see some of those over on the right-hand side. This is a fairly commonly used depression scale. And they're asking questions that are talking about things like changes in appetite. And if you know someone who's otherwise healthy but depressed, they do have that. Some of them gain a lot of weight and eat all the time, and others lose a lot of weight because they can't eat at all. But this is also a common symptom of these chronic invisible illnesses. Sleep and fatigue, we've already talked about. The ability to work. If you have one or more of these chronic invisible illnesses, it's very difficult to work and to be able to think well enough through the brain fog to be an effective worker in the workplace. They ask questions sometimes about, do you worry about your health? Well, certainly if you don't feel good, of course you're worried about your health. And if doctors are not able to come in and help you to figure out why you're not feeling well, of course you're going to worry. And interest in sex, I mean, that sounds like maybe an innocuous kind of question. But again, if you're feeling awful 24/7, sex may not be something that you're interested in. And so again, those are some symptoms of depression, but they also really affect those with chronic invisible illnesses as well. So there are challenges that the people in the chronic illness community have. And so one of them is a lack of quality medical care. And again, I want to say there to our physician friends, there are so many physicians out there who truly want to help. The science is not there for a lot of these. We need more funding for research. There's a lot of work to do. So a lot of these are difficult to diagnose, even for those healthcare practitioners that truly want to help. Secondly, they're difficult to treat. Again, the basic science is not there. For most of us, the best we can do is treat our sleep disturbance and treat our pain and treat depression. So we try to manage the symptoms without really understanding the underlying cause for all of these symptoms. And that's a difficult job for the physicians, and it's a difficult way for us to live as people in the chronic illness community. The second one, and I think many of you know this well, is the idea of this stigma. And again, I think it's because of the invisible part of these illnesses. You can see the picture on the right. This is a friend of mine who has POTS, who has a lot of issues, physical issues, but she looks just gorgeous. She's in a hospital gown there, and to look at her, you might say, gosh, what's going on? Boy, that's not fair, right? People know when they're sick. And so this idea that the illness is all in her head or all in your head is really hurtful. And so a lot of people do believe they can't see it, and physicians are included in this sometimes. They run the tests, they feel like they've done the due diligence, and they can't find anything. And so they label it as a psychological problem instead of a physical problem. And then there are the physical barriers. It's harder for people with a lot of these illnesses to get out. They have decreased mobility. So getting to work or to school or the grocery store can be much more difficult than it can be for their healthy family members and friends. Memory issues and confusion can be part of this brain fog as well. And just a general poor quality of life is common, especially in people that are at the more severe end of these chronic illnesses. There are some other factors in play here as well. For instance, grieving the loss of a healthy body. I think when many people develop these chronic illnesses, we hope that it's like the flu, that we can go to the doctor and we can get some help, and maybe we don't feel good for a couple of weeks or maybe even a couple of months, but then help is going to be on the way, and that we can return to our normal healthy bodies. And for many chronically ill people, that's just not the case, and there needs to be some allowance for the idea of grieving the loss of their healthy body and for what that means. It may mean a change in the plans that they had for the future. So with this, again, these physical barriers, feelings of isolation and loneliness, and then redefining their roles in school or work or relationships. And the loss of hope can come in here as well. And so these are very difficult problems for many people with a variety of chronic illnesses. We're going to come back to this idea later, but this idea of feeling like a burden to their loved ones is really huge when we start thinking about suicide risk. And sometimes it's difficult, I think, for our loved ones not to feel like a burden. If it's difficult for them to get up and cook or to clean or to go to the grocery store, even if the loved one says, I want to help you, I love you, don't worry about it, there's this internal perception a lot of times that they're a burden on that loved one. Sometimes they feel judged. In some cases, unfortunately, friends and family don't believe that the person is ill, and they'll withdraw that love or support. It can really be difficult for the chronically ill person. And then there are financial pressures, and I think a lot of families deal with this. It comes from a variety of different possibilities, but medical bills as we go from doctor to doctor and run all of these tests to try to figure out what's going on. Medications. Many of us take many medications and supplements every day. And then if the inability to work gets thrown in there or insurance problems, that can further exacerbate financial pressures for that chronically ill person. So as we think about the challenges that we see in the chronically ill population, I want to switch a little bit to thinking about suicide. And I want to start with just the general population, and then I'm going to talk about what the real issues are for this chronic illness population. Overall, in the general population, suicide is the 10th leading cause of death in the United States for people of all ages. So this is something that we need to be talking about more and thinking about more, not just in the chronic illness community, but also as a nation. We know that women are more likely to make suicide attempts than men, and the statistic is that they will attempt suicide 3 times more often than men do. What's interesting is that a lot of times women survive those attempts, and men are much more likely to actually complete the attempt, meaning that they actually will die by suicide. And when we look again at the general population, look at the ages that are thinking seriously about suicide. And it's that same age that we showed for a lot of these chronic invisible illnesses, that 18 to 50 age range. And so this is alarming for our population as well. You can look in a variety of places and find the risk factors for suicide. What I did is reorganize these into the risk factors that are most prominent for the chronically ill population, and I put those up at the top in yellow. And so notice what we see here. Major physical illness. And so I think everyone listening here either has one of these themselves or has a loved one that has an illness. That sense of isolation and hopelessness that we were just talking about. Job loss or financial issues that may be related to the illness. Loss of relationships and lack of good health care. So all of these can serve to increase the risk of suicide in our chronically ill loved ones. I want to point out here that particularly in the chronic illness community, suicide is not always related to depression. And this is something that I've really been thinking about and looking at in my own research. I think a lot of people think that, of course, not everyone who's depressed is suicidal or thinking about suicide, but I think we often go the other way, that everyone that's suicidal or that makes a suicide attempt is depressed. And I'm here to argue that that's not always the case. Here's what we know. For people who are at risk of suicide in the chronic illness population, many of them don't have a mental health diagnosis. They are not clinically diagnosed with depression, anxiety, bipolar, you name it. They don't have those diagnoses. In this population, I would argue that it's a response to physical suffering, to not wanting to live in the body that's filled with pain and fatigue and brain fog, and that's let them down, essentially. And so for many in the chronically ill population, it's more likely that suicide is a mechanism to try to relieve permanently their physical distress. Another way to think about this is what's called life weariness. And people that have life weariness don't want to go on living the way that they're living today. That's different from wanting to die, right? And there's an opportunity there to try to change that life for them. And then the last one there, as you can see, is that negative treatment by healthcare practitioners can also increase the risk of suicide. And so if you've got a healthcare practitioner that is belittling you or is not believing your symptoms, please look for someone else. There are good, caring healthcare practitioners out there. And so, again, some factors that can increase the risk of suicide in the chronically ill population, the physical illness or the multiple physical illnesses in themselves are risk factors. I've written several papers about this myself. We know that chronic invisible illnesses, all of them that I'm talking about tonight, can increase suicide risk. Functional disability, that idea that I can't take care of myself, I can't bathe myself or brush my hair or whatever the case may be. And then chronic pain and sleep disturbance. So we know that all of these can come together to increase the suicide risk in our populations. When we look specifically at data, and I just pulled a few numbers out of a few studies here for these chronic invisible illnesses, we see that in myalgic encephalomyelitis and chronic fatigue syndrome, that the second leading cause of death in that community is actually suicide. That's terrifying, right? Another study estimated that about 20% of people who have been diagnosed with those disorders die by suicide. Really scary. Again, a study that I did with my friend Jill Brooke and published a year ago found that about 48% of those that responded to our survey who had POTS and a variety of the disorders that we're talking about tonight were at high risk for suicide. A study looking at patients with fibromyalgia found that a third of them are likely to experience suicidal ideation, meaning that they're thinking about suicide in a serious way. In those with hypermobile EDS, this study is a little different. We're looking here at those that actually attempted suicide, and about 4% of people with hypermobile EDS in that study had attempted suicide. And then in the chronic Lyme, that untreated Lyme community, the estimate is about 1,200 deaths per year by suicide in that population. And so again, this is something that we need to be thinking about. We need to be talking about more as a community so that hopefully we can save the lives of our loved ones. Let me talk a little bit about some warning signs. I think it's important to know what to look for in your friends or family members. And so certainly if someone's talking about suicide, if they are saying, I want to die, or I can't imagine going on living this way any longer, that's something that we need to take seriously. If they're talking about feeling trapped in their body, feeling trapped in situations, we need to listen. Feeling hopeless, being a burden to others, unbearable pain. These are all things that we've already talked about in this webinar as being real problems for many people that have chronic invisible illnesses. We know that extreme mood swings, so if that person starts to behave in a way that's out of character for them, that can be a sign that they're thinking about suicide, that they're really not feeling good. Saying goodbye and giving away prized possessions, that can be another sign that they're thinking about suicide. And certainly if you notice that they're actively developing a plan, they're talking about a plan, they're trying to get access to lethal means, certainly that can be a sign as well. I think there's a golden opportunity for healthcare practitioners to help prevent suicide. And I was shocked when I read this paper that came out just a couple of years ago. And it's a fascinating paper, and here's what it boils down to. Of people that are thinking about suicide and who attempt suicide, 64% of them, almost two-thirds, visited a healthcare practitioner in the previous month, and 38% visited in the week before they made a suicide attempt. And so again, I would argue that there's a golden opportunity here for healthcare practitioners to ask about suicide, to start a conversation about suicide, and see if that's something that needs to be addressed in that particular patient. There are a couple ways that they can do this kind of screening. One is online questionnaires, and I don't know if you've visited physicians like this, but my daughter has and I have, where they ask about physical symptoms online before you even go to the appointment, or they hand you a tablet when you walk in and you fill out a series of surveys. One of those could be a brief suicide screening survey. The other thing they could do during the appointment is simply ask, are you thinking about suicide? And if they are, again, this is an opportunity to intervene and maybe catch those thoughts early before there's a plan in place. So healthcare practitioners and the people in their office can generate a handout that they can give to people with chronic illnesses that are thinking about suicide. And so they can give contact information for the National Suicide Prevention Lifeline. You can see the number there. And talk to a crisis interventionalist who's been trained to talk about suicide and help them work through their issues. A lot of the younger generation don't want to talk on the phone, they want to text. And so within the last couple of years, Hotline has come up, and again, you can see the number on the screen there. And this is a way to talk with a crisis interventionalist via text instead of on the telephone. Many communities have a chapter of the National Alliance of Mental Illness. They have a lot of resources to help people that are thinking about suicide that are in place already. And so finding that community organization and giving their number can be great. You can see in the picture on the side there are some other things, some other websites that would be great to share with patients. There can also be community resources that can be really helpful to that chronically ill person who's thinking about suicide. And so compiling a list of people who understand suicide, maybe they have a friend or family member with a chronic illness, and are willing to think about and talk about that with patients, or frankly, those that are willing to learn about chronic illness. So social workers, counselors, religious leaders, and suicide support groups that are willing to fold in chronic illness, chronic pain, sleep disturbance as part of their conversation can be hugely helpful to that chronically ill patient. So they can help get them to the proper resources. But healthcare providers can do more than that to try to treat some of these risk factors, and I would say aggressively treat things like chronic pain. So we already talked about how debilitating that can be for so many people with these chronic invisible illnesses. And there are a variety of ways to treat chronic pain. Again, the best time to do it is in that first 6 months. That doesn't always happen. Never give up hope. But medications are one way to treat pain, but they're not the only way. So even if you're using medications, you might try, or the doctor might ask you to try acupuncture or massage. This is just anecdotal, but I know several people for whom acupuncture and massage really helps with their pain, in addition to medication and some other things. If anxiety is part of the issue, biofeedback could be hugely helpful in treating the pain, as could meditation, physical therapy. And then some find that using a TENS unit where you put a little bit of electrical stimulation in that area of pain can actually help to reduce that pain as well. Here's what's exciting about pain. Right now we're not great at treating it. Again, it's a symptom that we try to cover and stop without really understanding how pain is generated in our body. Pain is one of those that's really a black box for us right now. But here's what's exciting. We are just starting to get some basic science on pain. They're identifying some cytokines and some other inflammatory molecules that are implicated in pain. And if those turn out to really be part of that pain cycle, we're hoping to develop some targeted medications that go at that cytokine or at that inflammatory molecule instead of just trying to numb out or stop the pain in other ways. And that's not here yet, but I think it's coming. I think it's coming in the next decade or so. And so there's a lot of work that needs to be done and hopefully is being done. Another thing that I think that our healthcare practitioners can aggressively treat to try to decrease suicide risk is that sleep disturbance. And sleep is another one that is complicated. There are so many factors that go into poor sleep. But again, I think so many people with chronic illness have this problem. And there are lots of things that you can try. And again, sometimes a combination of factors can work better than just trying one thing, like a medication. For some, a 10,000 lumen light that you use in the morning can be helpful. Again, this is anecdotal. My daughter uses this, and it has greatly helped her sleep. When she forgets to use her light in the morning, especially if it's more than a day or two, she does not sleep at night. And so you can buy this on Amazon. People use it for seasonal affective disorder, and it resets the brain. It wakes the brain up in the morning, which can help you sleep later at night. There are sleep supplements. I think many of you maybe take some of those supplements. Magnesium, 5-HTP, melatonin is a common one. There are some medications as well. So if sympathetic surges or that adrenaline surge at night is a problem, clonidine can help to slow that down or stop that. If anxiety is part of the mix, Klonopin or Xanax sometimes can be helpful. Talk to your doctor about ways to help you get a better sleep at night. If they can treat your sleep and get you sleeping better, that decreases the risk of suicide. And then there are all sorts of sleep hygiene things that you can do. So again, meditation and relaxation techniques before you go to bed at night or as you're laying in bed, limiting the stress and caffeine in the evening. If you're well enough to exercise, don't do it in the couple hours before bed. Do it maybe in the late afternoon or earlier in the day, and that can help you to sleep as well. I would also argue, of course, that healthcare providers should aggressively treat depression and that they can reduce the suicide risk by doing so. Again, I can almost hear the collective groan for the exercise. And I know that many people with chronic invisible illnesses just cannot exercise or can only do a little bit at a time. In the healthier population, though, they have really shown that exercise works as well as a number of antidepressants for mild to moderate depression. And so do what you can with that. Medications can also be helpful here. And there are some antidepressants that if depression and chronic pain are comorbid, if you suffer from both, that there are some medications that can treat both. So some older antidepressants like tricyclics, the one in particular called amitriptyline, that can help chronic pain as well as depression. And then serotonin, norepinephrine, reuptake inhibitors like Cymbalta can also help both of those. Talking to a counselor that understands chronic illness can be so helpful as well, even if you're not depressed, frankly, because there are so many things that go with chronic pain, with chronic invisible illnesses that you need to work through, grieving that healthy body, changing what you're looking forward to maybe in the future. And then electroconvulsive therapy, I know maybe that sounds a little bit excessive, but the truth is it's not the same as it was 20 or 30 years ago, and for some people that can be really effective. And, as sort of common sense, I think, healthcare practitioners can help prevent suicide by practicing compassionate care. And hopefully everyone in the chronic illness community has a good compassionate caregiver or health practitioner, but unfortunately I'm not sure that that's always the case. And so there are things that healthcare practitioners can do that will really help. Practice compassionate care. Believe patients when they talk about their illness. Even though it doesn't come up on the blood tests or the other testing, believe what they say. They're not making this up, right? Nobody would make up these chronic illnesses. We know that some recent studies have started to show some abnormalities in the blood, some physical abnormalities in blood tests that are showing up now for myalgic encephalomyelitis, chronic fatigue syndrome, for Lyme disease, and for POTS. We're not at the point yet where we can diagnose them very easily this way, but I hope that's coming. 20, 30 years ago, when people had multiple sclerosis, And they couldn't walk. We thought that it was a psychological disorder. And then we invented the CAT scan and MRI, and now we say, oh, of course, that's a physical problem. Look at the plaques that are in their brain. I hope that's coming. I think that's coming. Again, that's the basic science. We need more research. We need more work in all of these illnesses. And I think that will help. The physicians and the other healthcare practitioners can listen without judging. Try to truly listen to what that person is saying and be genuine in your concern, not thinking about how you want to respond, but truly being there in the moment. And try to leave them with some hope. That things can get better, that you will continue to work with them. You don't have all the answers as a healthcare practitioner, but that you are going to continue to try. You're not going to give up until you find something that at least can make things a little bit better. There are things that healthcare practitioners and others can do as well to help prevent suicide. Online support groups can be great. Again, they're maybe not always the best way to get medical advice or to change the treatments for yourself or for your loved one, but they are people who get it, who understand the physical limitations, who understand feeling like a burden, who understand the chronic pain. And it can be immensely helpful to that chronically ill person to know that they're not the only one who's suffering in the way that they're suffering. Again, this idea of going into counseling with someone who gets it, who has a chronic illness, has a family member or friend with chronic illness or chronic pain, or who is willing to learn. It can be so important. Learn those warning signs for suicide, and when people start talking about suicide, take it seriously. Get them into a counselor. Get them into the doctor. Take a step to show them that you care. And then the caregivers. It's important for caregivers, friends and family members as well, to learn about the chronic illness that person has. And again, there are so many chronic invisible illnesses. I'm thinking about ulcerative colitis, and I'm thinking about IBS and Crohn's disease, hitting sort of the GI tract. There are so many of them. Learn about the symptoms, learn about the triggers so that you can better understand what they're talking about. But caregivers, we need you to guard your own health as well. You can't take care of your chronically ill loved one if your health goes down the drain. So I would argue that caregivers can really benefit from support groups, again, whether they're online or in person, just to not feel quite so alone there. If we can identify suicidal thinking in the early stages, we can intervene. We can save that life. And so it doesn't mean that we necessarily, if they're talking about thinking about suicide or not wanting to live this way anymore, it doesn't necessarily mean that we need to put them into a mental institution, but it does mean that we need to do something. We need to go to the doctor and aggressively treat symptoms. We need to think about going into counseling with someone that understands chronic illness. And we can work on improving the relationship dynamics. What's going on for that person while we're waiting and we're trying things on the physical side? What can we do on the emotional side to help? How can we decrease those feelings of burdensomeness? Am I saying something that makes you feel like a burden? Because, gosh, I didn't mean to, right? Having those conversations and being aware can be really helpful for our chronically ill loved ones. And then trying to decrease loneliness, Again, when it's hard to get out of the house, it's great when someone texts and just says, hey, how are you doing? Or stops by. So the interpersonal theory of suicide was developed in 2005 by Thomas Joyner, and he was really looking at psychiatric inpatients. But I've read a lot about this theory, and I think it really applies well to the chronic illness community as well. And so what he talks about is this idea of perceived burdensomeness. So if you look at the balloon on the left there, perceived burdensomeness is feeling like you're a burden to family and friends. Now, they may or may not be giving you signals that you are a burden, but it's this feeling, this perception that I am a burden on the people that I love. And again, in the study that I did with Jill a couple years ago, we found that 97% of people that took that survey with POTS and comorbid disorders were limited by their illness, and that 30% of these people needed help with basic personal care. Again, bathing, brushing their teeth, that sort of thing. 25% were so disabled that they couldn't work or attend school. And again, remember, we're talking about women in the POTS population typically between 15 and 50. Now, they can be younger than that and they can be older than that for sure. But we're not talking about people who should need this kind of help. It's their illness is really debilitating. There's another study that showed that in people with chronic pain, that they often feel like a burden on their friends and family. So part of this interpersonal theory is that feeling like a burden, this perceived burdensomeness on family and friends. A second part of it is called failed belongingness, or in this graph that I've got on the side, they're calling it low belongingness. And the idea is that people feel like they're not part of any social group. And there are reasons for this, again. But think about that. If people feel like they don't belong with a group of friends or within their family, that's very difficult to think about and deal with. 76% in that same study that I did with my friend Jeff Brookings found that 76% had high or very high levels of loneliness. And again, in both of these cases, the physical limitations, the inability to get to work or to school, and the different life expectancies, or experiences rather, the different life experiences, where it's so difficult to relate to other people because it's difficult to get out of the house. Or you go and make an effort for a couple of hours and then you're laid up for the next week. It can be very difficult to relate to people who are healthy, who just don't get it. Here's what we found in our study. That perceived burdensomeness, feeling like you're a burden to friends and family, is actually may be a more important risk factor for suicide in chronic illness population than failed belongingness, loneliness, or depression. Let me say that again. That feeling of perceived burdensomeness in our chronically ill loved ones can be a more important suicide risk factor than not belonging or feeling like you don't belong, than loneliness, or than depression. This is something that, again, we really need to be thinking about and working on to decrease that feeling of burdensomeness in our loved ones. So the question is, after all of this, how can you help? How can I help as the parent of a chronically ill child? And I think it's not rocket science, right? I think for friends and family members, we need to believe them when they talk about their symptoms and their suffering. And sometimes maybe we get tired of hearing it, or we're not in a good mood, and maybe we snap. But the best we can do is the best we can do in that moment, right? So just do the best you can. Some days are going to be better than others, but believe them when they talk about their symptoms and suffering. And don't try to fix that illness. I know people want to help, but a lot of times adding a vitamin or just exercising is not going to get rid of these. And believe me, people with these illnesses or with this pain, they would do anything to fix it. Staying in contact. So again, sending a text once a week. Hey, how you doing? I'm thinking about you today. Can be hugely uplifting to someone with a chronic illness who can't get out, particularly if they have trouble getting out of the house. Be understanding when plans get canceled. Like most humans, people with chronic illness are optimistic And sometimes they make plans and really want to do things, and their body just won't allow it. And so if plans get canceled, don't make them feel badly about that. Say, hey, no problem, we'll catch you next time. And maybe what you can do sometimes is plan activities in their home, where you're in their living room and you have a movie night, or you have a game night on the floor, or something that's fun that everyone will enjoy that doesn't require travel and doesn't require a lot of extra noise or things outside of the home. And then again, take the talk of suicide seriously. It really is important to intervene and not to be afraid to talk to them about it. It turns out that talking about suicide will not increase their risk. So if you're concerned that a loved one's thinking about suicide, don't be afraid to ask them if that's the case. Here are some great things to think about to guide a conversation about suicide if you're concerned about a loved one. And some of these are questions that maybe you ask yourself as well. But is that person getting the best medical care? Should we try another specialist? Should we try somebody else who might come at the illness from a different angle and be able to give a little bit of relief, even if they can't cure that person? Does the chronically ill person have someone they can talk to, someone who listens and understands and cares? Do you have hope for the future? Is this someone who's looking ahead, right, who's making plans and has dreams for their life? Are you lonely? If they're lonely, boy, this is one that's easier to fix. Call on your friends and family to really work in a systematic way against that. Do you feel like a burden? We've been talking about what an important question that is and trying to figure out how you can decrease that feeling of burdensomeness. Does thinking about suicide provide you with comfort? Don't necessarily be alarmed if the answer to that is yes, because again, it can be that life weariness. But what can we do? What steps can we take to try to make that better? And then the last one, I think, is probably obvious. Do you really want to die? Or is it that you just can't imagine continuing on like this? And so I think for many with chronic illness, the answer is the latter. They're not necessarily wanting to die, but they can't imagine continuing on like this for the next number of years or decades. This is my last slide. This is my call to action. If you don't remember anything else from the talk, I hope you remember this. I think as a community of people who have chronic illness and who love people with chronic illness, we need to be warriors out there. We need to go out and educate others about chronic illness. Sometimes we play the role of educating our healthcare practitioners. And when you do that, you're helping the next person, right? And we also need to talk to people about looking fine doesn't mean that you're feeling fine, though. So many of these illnesses are invisible. And we can't tell by looking at them how they feel on the inside. We need to consider the risk of suicide even if the person is not depressed. Again, please don't be afraid to ask about suicidal thinking. You are not going to trigger something or cause someone to make an attempt. And then a lot of times it actually brings relief to that person to have someone to confide in about that. It releases the tension and they start to feel a little bit better. Work to decrease the feelings of burdensomeness, failed belongingness, and loneliness. Again, don't be afraid to talk about, is there anything that I do? Am I doing something that I don't mean to that's making you feel bad? Because I want to change that. I don't want that to be your experience. And then, of course, go aggressively after these treatments for the physical sides of this, for sleep issues, for chronic pain, and for depression. And again, getting rid of that sense of hopelessness or isolation through a support group, whether it's in person or online, can be absolutely essential. And so what I hope that I do every day for my daughter and I hope that you will do for your loved ones, is try to be that one who listens and tries to understand. And again, we're not going to be perfect at that every day, but do the best you can every day to try to listen and understand, and you could save that life. You could save the life of a loved one. So thank you so much for listening to the talk. I really appreciate your attention. And I can see that there are some questions up there, so I'm going to look at some of the questions and do my best to answer. Let me remind you that I'm a college professor, and I am the founder of Standing Up to POTS and a mother of a chronically ill child. So I am not a physician. I'm not a lawyer, and I'm not a counselor or a therapist. Okay, so I'll do the best that I can to answer some of these questions.
Thank you, Cathy. I think that was a very clear understanding of what many of our chronic pain members are experiencing. Ehlers, Danlos, as well as POTS and Dysautonomia, those are really issues that they struggle with. And I think you made it very clear and outlined a lot of good information, some good suggestions, ideas on how we can help those people. So really appreciate that. And yes, we do have a few questions that you can go to at this time.
Okay. So the first question is asking about the legal obstacles to getting the medicine that chronic pain sufferers need to decrease their pain. And is that a problem for suicide risk? And I think the answer to that is yes. It's in the news all of the time now. The opioid crisis is a huge problem in the United States and in many developed countries of the world. And we're putting more obstacles, more legal obstacles in place that make it difficult for the true chronic illness sufferers to get the medications that they need. And we know that some people with chronic pain, they will respond to amitriptyline or Cymbalta or some of these other non-narcotic, non-opioid types of issues. But there are others for whom they've tried many, many other medications and they just don't work, or they worked and then they stopped. And so, yes, I think this is a real problem for people with chronic pain. And I think the pendulum is swinging. So for the last decade or two maybe, it's been easier for many people to get a opioid prescription than maybe it should be. And now we're swinging back to now where it's very, very difficult for people who really need it to actually get it. And I think this is going to be a real problem for us in the chronic pain and the chronic illness arena. And I don't have a good, easy answer to that. I think this is a real problem for us, and we need to keep talking about it. There is a risk, obviously, of becoming addicted, but if that's all that works for people that we know have true chronic pain and chronic illness, there's got to be another way to deal with that. So thank you for that question. Scrolling down to the next question here, and this is from a parent who lost their son to suicide in 2013, who had a number of the illnesses that I talked about tonight. And let me say first that I'm so sorry for your loss. That's just an unimaginable pain, and I'll tell you the truth, a lot of the work that I'm doing now is because I'm scared for my own daughter, who is not depressed but has lots of pain and has POTS and EDS and a number of other disorders as well. And so she's talking about being in some suicide support groups and would like to share some of the information. That'd be great. It'll be available on the website after this is done. I think John's going to put up the slides and the talk as well, so that people can get to it afterwards if they missed it this evening.
We'd also like to, Cathy, we'd also like to put a listing of those articles that you referenced, because it sounds like those are really good references that allow people to learn more about this. So we'll do that.
Absolutely. As well. Yeah, absolutely. I'd be happy to do that. Some of them I get through the university, but the ones that are free access, we will absolutely put the links to the full articles up there. Yeah, I'd be really happy to do that.
Great.
And so her question is, can she share this with the suicide support groups and educate families? And I hope that you do. I think the suicide community is not very aware of this chronic illness population and how they fit in. And so I've actually written a couple of papers with people whose specialty is in mental illness. So they're counselors and psychologists and social workers. And they weren't really aware of this population, and so it's really opened their eyes, and we're publishing in a lot of areas trying to get the word out on this. Yeah. And so there's another question about palliative care options for those with serious chronic illness and anything in the works. So that's a really interesting question. Palliative care is where you're not trying to prolong life. So I think of palliative care with cancer as a good example, where you're not necessarily trying to kill the cancer anymore. You may not be doing chemo or radiation, but you're just trying to make the person comfortable. And so palliative care for people that are suffering from some of these chronic invisible illnesses, and some of them have quite a few other illnesses apart from what I've talked about tonight, should absolutely have access to some of these medications, and especially if it looks like the lifespan is not going to be decades, that we should absolutely be treating this. I'm not up on the palliative care treatment for this. I've got a friend who does it with kids and cancer, and so I know a little bit about it from talking to him. But I don't know if there's anything in the works for people with chronic pain or some of these chronic invisible illnesses. And then the next question is, do you or can you connect with people who are struggling with peer support specialist or a life coach if they aren't in mental distress? And I think the answer to that is yes. Again, when we're thinking about suicide risk in this population, it's not necessarily depression. It's not necessarily that tomorrow they're going to go out and execute a plan. But there is so much else that goes on with it. So in kids not being in school, they lose some of those friendships and relationships. They're not going to the football games. There are just so many things that go with it that I think a peer support specialist or a life coach is a wonderful idea. And to do it before they're in mental distress, I think, is a wonderful idea for so many people with chronic illnesses, because, again, it's more than just the physical side that they're dealing with here. The next question is, are there online psychiatrists and psychologists who specialize with chronic pain, EDS, and fatigue? And I only know of one, and that is through the Dysautonomia Clinic. And they're based in New York. It's Dr. Blitzstein and her team. And they've got a nutritionist, but they also have, and Dr. Blitzstein herself, who's an autonomic neurologist. And then they have an online psychologist, I believe, who has some chronic pain and some of these chronic illnesses herself. That's the only one that I know of online that's working like that. I think it's a wonderful service, and there may be others out there that I'm unaware of. But this would be a great way to work. I think telemedicine in the next decade or so is going to be an important tool for those of us with with chronic illnesses because it is so hard to get out of the house, or you're sensitive to smell or light, or all of the noise is problematic. So I love that question about the online help, and I do think that some of that is there as well. And then the last question that I see here is a relationship with hormonal imbalance and chronic fatigue and rebound fatigue. I don't know that I've read papers on that. I know about the chronic fatigue and rebound fatigue for sure. I don't know about hormone imbalances. Again, this is anecdotal in my own case. My daughter has both of those. We went to an endocrinologist and really had her checked over and didn't find anything there. That's not to say that having a hormonal imbalance wouldn't exacerbate that fatigue or the rebound fatigue. It's quite possible that can happen. And then the second part of that question was, what do you advise for those with severe rebound fatigue from psychological stressors? Boy, that's the $1 million question right there, isn't it? So it doesn't have to be going on a family outing or having people into the house. Sometimes it's the stress of knowing that you can't go that can cause that rebound fatigue. And I don't know what to say to that one except that using, again, a counselor to deal with some of those psychological stressors, meditating, finding other ways to function in that community, where again maybe you're doing it by text message instead of in person. Maybe part of that. I wish I had a better answer for that. That is absolutely the $1 million question for so many with chronic illness, chronic pain, and chronic fatigue. All right. So
thank you, Cathy. I think you've really spelled out a lot of good information for our members, and this is a topic that isn't talked about enough and really needs to be discussed more. And I appreciate the way you've organized your ideas and thoughts. We're looking forward to getting this recording on our site and also listing of many of the resources that you referred to along the way.
Absolutely. I'd be happy to pull that together and put that up there. Well, thank you all so much. I really appreciate the opportunity to talk to you about this tonight.
And we do as well. So appreciate all of those that have attended. And again, this recording will be posted in the next couple of days on our site, plus a number of articles. So please promote it with many of your members who you feel would be, and peers, maybe doctors, and also support groups, so that they have access to this information as well. So we'll close out this evening. Any final comments before we wrap up, Cathy?
I don't think so. Just to say that I really appreciate your attention. I see some of you saying that you appreciated the presentation. I appreciate that very much. And let's get the word out. Let's go out there and save a life. Okay, fabulous. Thank you. Okay, well, we'll call it evening, and thank you for attending. Go out and listen to this and promote this webinar, as well as the 80 other webinars that we have out on our site on various topics related to EDS and associated conditions. So thank you for attending, and thank you very much, Cathy, for your presentation. And we're going to call it an evening. Good night. All right. Good night.